Good morning, everybody. I am Dr. Jitendra Agrawal, Medical Director, Sanjeevan Hospital, Surya Prabha Nursing Home. Today, we'll see a case answer of a last time presented to you. A 62-year lady presented with right hypochondriac pain, with fever, with chills, with very high WBC count, was in shock, dehydrated, mildly icteric, and there was no other clinical signs. She had developed E. coli on her blood culture and she was having acute kidney injury with creatinine 1.5. The question was, what was the diagnosis? What are the commonest organisms involving in this condition? What are the diagnostic tests we'll ask for? What is the common source of the organisms and how to treat these conditions, and what is the long-term prognosis in this particular patient? So what is the likely diagnosis in this patient considering her high-grade fever with rigors, with right hypochondriac pain and vomiting, low blood pressure, oliguria, raised WBC count, positive blood culture going E. coli, suggestive of septicemia and septic shock, and this is caused by biliary tract disease, especially ascending cholangitis. So what is cholangitis? Cholangitis is a inflammation or an infection of the hepatic and common bile duct associated with obstruction of the common bile duct. The differential diagnosis for this condition is biliary colic and acute cholecystitis. Both of these presents with acute abdominal pain associated with fever, and this pain is right hypochondriac. It's a colicky type of pain, tearing pain, patient is in tear, patient can have vomiting, and there is high grade fever. It can be obstructive for various reasons. Then the liver abscess, which shows again fever with rigors but marked tenderness, especially in the right hypochondrium, and the liver abscess is commonest pyogenic and amoebic colitis, amoebic abscess. You can see the liver patients, especially patient with immunocompromised state, especially HIV patients, patients on chemotherapies, patients with malignancies, patient on steroids can have acute liver abscess. And the peptic ulcer disease is another diagnosis where you may not get high grade fever and rigors, but definitely there is abdominal pain and intractable vomiting. These patients can have infection because of the perforated peptic ulcer, and that's why you can get high grade fever and the septicemia with acute kidney injury, what this patient presented to us. Acute pancreatitis is another condition of a differential diagnosis, especially patients who are alcoholic, binge alcohol drinking, and thereafter severe abdominal pain, intractable vomiting. These patients can present with similar picture of high counts with septic shock and severely dehydration. The patient with intestinal obstruction will have again a high grade fever, especially when there is an obstruction associated with sepsis. These patients can have perforations, and again they can present with severe abdominal pain, but there is a distension, significant tenderness which is localized. You may not have a internal obstruction, you can have in the local right hypochondriac, but generalized tenderness if there is a perforation. The right kidney stone, especially pelvic stone, can present with this particular illness of acute abdominal pain, right sided, especially lumbar renal angle tenderness, along with the right hypochondriac pain. The right pelvic stone can present with this, with vomiting, with fever, and you can also have deranged renal function test, but you may not get a deranged liver function test in these particular patients. Patient with acute pyelonephritis also can present with this type of presentations. Of course, all these patients will have basically a renal status which shows the urinary derangements or urinary abnormalities in these particular patients. And of course, the patient of hepatitis can present with cholestatic state where you have rise in alkaline phosphatase, obstructive signs, abdominal pain, right hypochondriac pain, and tenderness. You can have commonest organisms in these particular patients, especially E. coli, which we have seen in our patient, then Klebsiella, Pseudomonas aeruginosa, and B. protease. Different diagnostic tests are suggested in this particular patient, especially ultrasound, CT scan, and ERCP. Ultrasound is very good for the visualization of gallbladder and common bile duct. to differentiate extrahepatic versus intrahepatic obstruction, but this is insensitive, but it is specific for the visualization of common bile duct. CT scan is a better option, but it is less accurate for gallstones, more sensitive than ultrasound for the distal part of the common bile duct, and it allows to visualize better evaluation of neoplastic lesions. ERCP is a confirmatory test for obstructive, specific test for this common bile duct evaluation obstruction and its levels of obstruction. It allows to get the specimen for cytology and culture, and of course it can be a therapeutic option for the patient. How to justify that this is cholangitis? Whenever you have WBC count more than 12,000, these patients suggestive of acute cholangitis, along with the renal function is presented here, which shows acute kidney injury, rise in creatinine. There are various KidGO and all parameters for acute kidney injury definition, but if you see from the baseline, if you have rise in creatinine level 1.5 times of the baseline creatinine levels, that is a sign of acute kidney injury. Patient has oliguria, patient is in sepsis, patient has hypotension. So these all suggestive of acute kidney injury. Any biliary pathology can lead to disturbance in LFTs, especially in our patients. There is albumin low, but all other parameters are high. That is obstructive type of pattern where alkaline phosphate is also raised. Raised CRP, you can see a sign of raised CRP means inflammation or infection. If CRP more than 20 milligram, it is significant. If more than 100 milligram per GL, that indicates profound inflammatory response in the patients. Look at the coagulation studies, especially this coagulation study and albumin are sign of sympathetic function of liver. The synthesis is affected, that's why PT is prolonged in this particular patient more than 1.3 usually. And if the surgical evaluation is required or surgery is indicated, then you have to correct these coagulation abnormalities. The patient in sepsis, so blood culture that grows the bacteria and gives a sensitivity to antibiotic panel, and that accordingly we can use the antibiotic in this particular patient. Amylase is distinguished for pancreatitis. It can also be seen in lower CBD infection or involvement, and raised pancreatic involvement of amylase suggestive of pancreatic involvement. And of course you have to go for the reading of the, this particular count is more than 3 times of upper limit of normal, so that is significant. The commonest sources of organisms involving this particular disease is basically urinary tract infection with or without catheterization, respiratory tract infection, and skin sores, especially those patients who are admitted in the ICU having bed sores. The bed sores is usually are the source of infection or sepsis in this particular patient. Various antibiotics of choice, especially ampicillin, sulbactam combination, you can give 3 grams 6 hourly, you can use azithromycin 2 grams 6 hourly, clindamycin 600 milligram 6 hourly to each hourly, gentamicin 1.2 gram 1.5 to 2 milligram per kg body weight. But you have to be careful when you have acute kidney injury. You can use this if you do not have any option, but in a renal dose, especially gentamicin, amikacin, you have to adjust the dose, especially peptides, peptidazine, tazobactam. According to creatine level, usual dose is 4.5 gram 3 times a day. The patients can also get metronidazole. You can have metronidazole, but the dose should be again adjusted with the acute kidney injury incidence, where you can normally you can give 500 mg 3 times or 4 times in a day. Other parameters like pain and vomiting can be treated accordingly. How will you manage this case? A non-pharmacological treatment, an acute general treatment. A non-pharmacological treatment is decompression of the biliary, the first choice, which is urgent in severely ill patients or those who are not responding in 24 hours for medical treatment, and performed semi-electively in patients who can also show a very good response. So what are the choice is ERCP first with or without symplectomy, putting a stent over there for the drainage, and the percutaneous transhepatic biliary drainage used to be the treatment earlier. Now endoscopic ultrasound guided biliary drainage with stent deployment and is a best choice, and of course surgical exploration of common bile duct. For acute treatment, keep patient NBM, hydrate him with the IV fluids, give the broad spectrum antibiotics which I have already mentioned in the previous slide. Such patients to be treated at the earliest, and accordingly once you treat these patients, look at the long term prognosis of the patient. What is the long term prognosis? That if not treated properly, this patient can go into sclerosing cholangitis, which is a rare chronic inflammatory condition where you have focal or diffuse fibrosis of the biliary ducts. This can be primary or secondary. Primary is idiopathic and secondary is because of trauma, stones, cancers or contagious infections. Right hypochondriac pain, intermittent jaundice, pruritus and cholangitis are the clinical presentation of these particular patients, and it may complicate into secondary biliary cirrhosis and portal hypertension with bleeding esophageal varices, or also can lead to acute hepatic failure. So such patients to be treated promptly and at the earliest, because considering her age, these are the patients who go into septic shock, acute kidney injury leading to renal failure and may need a dialysis. If not treated properly, these can go into chronic dialysis or the mortality is very high. Please go through the case, read again, read according to referrals, and these particular cases are quite common in day-to-day practice. Whenever you are nobody, whenever you are treating your indoor patients, always be vigilant. Look at the clinical signs. Always clinical signs gives us a demarcation of the various diseases and their borderlines. You have to treat these patients at the earliest so that you can prevent the mortality. If you have any question, you can ask me on my mail jka29405@gmail.com. Thanking you. Please have a great day. Keep safe. Take great care of yourself. Thank you.